Okay. Uh, Now shall we begin? Do you hear me, Professor Abbasi?
Yes.
Okay, let's start our today's webinar on emergency excellence. Good evening, everyone, and thank you for coming today, and thank you for your participation in this webinar. Before we start, I want to start this session with congratulating on the International Nursing Day worldwide. Before we begin today's presentation, I'd like to take a moment to acknowledge a very special occasion. We are all proud to celebrate International Nurses Day of 2025. Each year on 12th of the May, the world comes together to honor the birth anniversary of Florence Nightingale, the founder of the modern nursing. It is a day to recognize the dedication, resilience, and compassion of nurses across the globe. And this year it carries on a specially powerful message. The International Council of Nursing, ICN, has announced the theme of this year's celebration: Our Nurses, Our Future, Caring for Nurses Strengths Economies. So as you can see, this page is the main page of the ICN's website, and on this web page you can see this motto and the theme of the International Nursing Day for 2025. This themes builds upon last year's impactful message, the economy's power of care. So, as you know, for challenges in the lines of the economies worldwide, also International Council of Nursing has emphasized on economies and wants to highlight this challenge for the nurses also. This then builds upon last year's impactful message, the economy's power of care, and shifts our focus to something even more fundamental, the health and well-being of nurses themselves. This year theme is a powerful reminder that we care for our nurses. We are ultimately caring for our communities, our health system, and our economies. The upcoming IND 2025 reports to be revealed on May 12th will offer real evidence-based strengths for supporting nurses in the workplace strategies that we can implement now to build a stronger, safer, and more sustainable health environments. So today, as we begin our discussion, let's carry this message with us. Let us celebrate not just the profession of nursing, but also the people behind of this profession, the millions of nurses around the world whose health and happiness determine the health of all us. Happy International Nurses Day to all of you and every one of you. Let's honor our nurses, not just with words, but with action, support, and commitment. So this is Mahdi Nabi Foodani, PhD candidate at Tehran University of Medical Science, and it's my pleasure to serve as a facilitator and a speaker for today's webinar. We are delegated to have attendants from various backgrounds with us. Before we begin, let's make a quickly go over a few housekeeping points. Please keep your microphones muted during the session to avoid background noises. You are encouraged to post your question in the chat box. Of course, we will have a question and answer session at the end of all presentations, so do not hesitate to write your questions or ask them. The webinar will last approximately 1 hour. I hope you all have a good time with us. Let's, without killing the times, go straight to our presentations, and let me introduce the first speaker. Let's begin with our first speaker, Dr. Verónica Márquez Hernández, full professor at the University of Almería. Dr. Márquez will be present on ISNAID, one of the newest tools for caring for the patients in the emergency hospital. Dr. Márquez, if you're hearing me, the floor is yours.
Okay, thank you. Thank you, María. Hello to everyone. I'm Professor Verónica Márquez from the Faculty of Health Science at the University of Almería in Spain. I would first like to thank the University of Tehran and the University of Almería for making this webinar possible, and special thanks to Mahdi, Nabi, Foodani. I'm going to share my presentation right now. I think you see. I apologize for my voice, and if my English is not as good as expected, but I will try to do my best. I'm going to show you a new device, and the title of my presentation is Rescue Work Training with a Novel Device for Patient Extrication. SNAID is a device which aids in a primary necessity, which is that of the injured person who is in a life-threatening situation and quick removal is required. At the same time, the utmost care must be taken so as not to worsen or provoke any more spinal cord injuries. Secondly, to avoid occupational injuries for the rescue, and thirdly, to avoid contact with body fluids from the injured. What is it? SNAID is an innovative device for its dual function of craniocervical immobilization and extrication of victims in situations where quick removal is required, in cases of suspected cervical spine injury, and in environments with difficulty access, and in emergencies of life-threatening situations. In cases of enclosed situations where a very quick and urgent removal is needed because the injured person's life is at risk due to fire hazards, intoxication, or danger of instability, usually forced maneuvers are carried out with no guarantees, and they put the health of the injured person at risk. The consequences of this previously unable to assess because of the need to remove the injured immediately could be life-threatening or even cause irreversible motor damage such as quadriplegia or hemiplegia. In these times of emergency where the use of existing resources are not available, spinal board, one proceeds fortuitously to the immediate removal of the injured, pulling the accessible part of the body the closer, meaning that injuries can be aggravated or induced. In the best cases, if the physical build of the rescue and the injured are compensated in favor of the rescue, you can perform the Rautek maneuver for extraction. The rescue must have great physical strength, skill, knowledge, and training in order to carry out this maneuver, which bases its results on the use of the rescue body in three main areas. Firstly, he uses his body to transport the injured person, involving the need for physical contact between the rescue and the injured, which involves transmission of fluids and or direct contact with open orthopedic injuries. Secondly, a gripping method for the extraction, which is performed by positioning an arm of the rescuing across embrace around the injury. This positioning arm creates a reduction in traction of 50% and may cause occupational injuries to the rescue. This maneuver is curtailed in case of injuries or fracture of the upper limbs because of the very nature of the injury. And thirdly, as an attachment element in the cervical area of the injured using rescuer's head as support and the other arm for immobilizing the injured person's head. This does not guarantee 0 degrees immobilization in the cervical spine area or movement that can happen through the tractive effort at the time of extraction because of the place and the postural position of the rescue. This picture shows that to ensure a successful extraction, the physical strength of rescue is required to secure the cervical area with one arm and remove the injured from environment they are in with the other arm with the total weight of the injured falling on this arm. Wherever this maneuver route is impossible to successfully execute due to the particularities mentioned above, there is the need to provide a rescue element for professionals in charge for this action, who require the following: a guaranteed cervical immobilization of the injured area, ensuring prevention of occupational risks for the rescue, and a valid removal tool. For this reason, the snake the snake device has the necessary feature to guarantee these three needs. It consists of a flexible polypropylene core with attractive capacity exceeding 700 kilograms. It also has handles at the ends for gripping. The core is coated with a mixed composition of polymers formed on a flexible body. It has the morphological capacity to adapt to all types of anatomies, design, structure, and dimensions, which ensure cervical immobilization of 0 degrees and the control of involuntary movements, whether they be anterior, posterior, lateral, or rotational. Hypoallergenic, washable, removable, and replaceable outer cover used in contact with the injured. Upper limbs immobilization strap, ensuring the immobilization of the upper third part of the injured person's body. It is a medical device regulated by international standards. The snake, as you can see in the picture, has a design which consists of an elongated body with an approximate center thickness of 11 centimeters, made of foam density and memory effect that adapts to the front area of the injury, fixing itself between the chin, both mandibular branches to the mandibular angles, sternum, and the inner third of the clavicles, both anteriorly and lower. It is able to adapt to the head and neck to provide immobilization and fixation without putting pressure on the airways or vascular structure, carotid artery, and internal jugular veins. Lateral part for sternocleidomastoid muscle, mastoid trapezius muscles, and deltoids to ensure lateral immobilization. And back part, high side occipital, lower side cervical column. In the two outer thirds of the central part of the device, in number 2, in the picture, the diameter is reduced to cross over at the back of the head, providing occipital support and fastening on the upper side and cervical spine on the underside. In 2/3 of the ends of the diameter of the device is reduced to 4/6 centimeter, number 3 in the picture, so that they can pass under the armpits to the upper back of the injured person's body, leaving the handles available to grip the injured from a real position. In case of functional distension of the victim's upper limbs, the use of the immobilization strap is recommended as a supplementary method. Because of the support structure in the anterior, lateral, and posterior neck area, the device only exerts pressure used to pitch it, which means that the force the rescue uses to mobilize the victim is exerted on the clavicle, underarm, chest, and to a lesser extent, the trapezius muscle, lower side of the humeral head, and glenoid labrum, ensuring the rescue, removal, and safe lifting on the injured. From a rescue point of view, the use of the snake device ensures a quick and safe maneuver from a clinical standpoint when other methods, such as the spinal board or neck collar, can't be used due to the need of immediate removal or difficult access. Therefore, injured person is guaranteed cervical immobilization and a secure method of extraction, so that even having to tilt or lateralize the injured because of entrapment or confinement, being fixed on the upper body of the upper trunk, the required angular rotation is performed at a lumbar or hip level, such that the spinal injures both dorsal and cervical, which might have been caused during the accident, would be controlled and the risk of deterioration reduced. Snake design allows the rescue to carry out the maneuver at their will and with all the available resources with physical contact with the injured beyond that of the positioning of the maneuver itself. On the other hand, having no contact in the rescue effort using this maneuver prevents fluid transmission directly from the injured, as well as their own incision or contamination resulting from the maneuver. Snake does not replace any element that currently exists for this situation. The intention is to coexist with those already established and give the staff who carry out these rescue operations another tool for those cases in which the resource that they have mean their safety is not guaranteed, as well as the safety of the injured in hostile environments. It can also be used as cervical immobilization element for moving the injured. In conclusion, the snake device is an improvement of quality of care in the immobilization and extrication in emergencies due to its speed, security, and simplicity of application in complex situations and limited resources, and for its versatility for cervical immobilization, movement of the injured, and removal to a safe place in dangerous situations. Snake saves time, and time is life.
Thank
I
you.
want to show you some picture for ambulance type B and C in the European Union. Also, in fire rescue and civil protection departments in the European Union, you can see a simulation workshop. And this device, it has been approved in different organizations, in medical emergencies, Spanish organization, also for university, for army, and for fire department too. And I want to share with you our last study. It's about the effect of rescue work training in nursing students with a novel device, a quasi-experimental study, in which in this study we use this device training with our nursing students. So, and finally, I want to show you some video about the snake.
Professor Márquez, thank you for your valuable presentation. It's very useful and practical for me. Dr. Nabi, do you hear me?
Yes, Professor Marquez is trying to show us a video, but I cannot see it yet.
Right now?
Yes, we can see it now.
Okay. So thank you so much for your time and your attention.
Thank you very much, Dr. Marquez, for that insightful presentation and your efforts. Thank you for coming and joining today's webinar. It was a pleasure for us. If you are done, I want to introduce the second speaker. Okay, now let's move on to the second speaker, Professor Carmen Rodríguez. She is an associated professor at the University of Almería, and the topics that she is going to present is the Spanish triage algorithm. Professor Rodriguez, the floor is yours, and we are waiting for your insightful presentation.
Morning to everyone. First of all, I would like to introduce myself. I'm María Carmen Rodríguez García, and I'm one of the professors of the Faculty of Health Science of the University of Almería. I would like to thank to everyone who has been charged to organize and make possible this webinar today. Well, I will start with my presentation. First, please let me know if there are any problem during the presentation, or you can not see properly the slides.
Professor Rodriguez, we cannot see your slides, so if you are
Okay.
sharing them, please do that now.
Now?
Yes, perfect. We can see it now.
Okay, so as Mahdi said, I will start my presentation speaking about the set. Set is a structured 3H system that we usually use here in Spain, more specifically in the Andalusia healthcare context, in hospital 3H. As we know, in hospital emergency departments, it's really important to identify and prioritize patients in emergency situations who need assistance in a short period of time. For this reason, the 3H instrument constitutes an essential and very important resource and tool for the emergency department. Regarding the concept and the definition of 3H, I would like to say that the term of 3H it comes from a French neologism which means choose, separate, or classify. The preliminary clinical assessment process that order patients prior to any diagnosis or therapeutic assistance according to the degree of the urgency or severity of the patient. For this reason, the 3H allows that the most urgent patients are assessed first. Depending on where, how, and when the 3H is carried out, it can be classified as in hospital emergency 3H, pre-hospital emergency 3H, or disaster 3H. We will focus the webinar of today in hospital emergency 3H. The emergency 3H is a fundamental and essential resource for ED's department, as we said before, because of it allows to classify the patient according to the level of the urgency in an equitable, efficient, and safe way by assigning a priority level in care of the patient. Also, the 3H helps to manage clinical risk and safe patient flow management when demands and needs exceed the resources available. For this reason, the 3H is an important resource to promote equitable care management and efficient use of the available resources, human, material, and structural in the different EDs contexts. Most of the ED use its responsibility or it's carried out for nursing professionals. In that case, nurses are responsible to assess the sign or symptom that are reason for the consultation in the patient. Afterward, they set the priority of care according to the level of the severity of the urgency of the patient. And finally, the nurse professional assigns the patient to the emergency room for assistance. According to the set, the 3H of the patient should be done before or during the first 10 minutes after the arrival to the EDs. The time of the 3H, I mean the time that nurses can spend with the patient during the first assessment, it should be not for more than 5 minutes to ensure that a quick evaluation or assessment is being done for the patient, and in order to set as soon as possible the priority corresponding to the patient clinical situation. The nurse, therefore, should register relevant information regarding observations, clinical signs, of vital of the patient to precisely set the priority level. In order to guarantee the effectiveness of this process, a specific profile is required for the nurse or in charge of the triage. Some of these features or characteristics are listed below. Starting with a specific training in emergencies or critical patient care. Furthermore, theoretical and practical training, more specifically in triage. Previous professional practice in the ED recommended between 6 and 12 months. Possess good communication skills, empathy, respect, and good interview technique. Quickly recognize and identify patients in life-threatening situations. Have the ability to make decisions, lead and manage the situation and the resources, and work in a team and delegate. Guarantee the safety of the patient from their admission to the service until the discharge, and update their knowledge of triage and ensure its proper use and operation during their job. The advanced triage gives a crucial role to nursing because it allows for the ordering of the diagnosis test and the administration of specific treatments according to specific protocols and clinical guidelines in the emergency department. Also, it allows acting and relieving the patient in face of 13 pathologies and clearly defined clinical signs, such as give some painkillers in patient with pain or paracetamol in patient with fever. All of this process it occurs before to the first medical evaluation, so it helps to contribute in a efficient clinical care for nursing professionals. As we said, all of these processes have clinical repercussions about the patient and also for the clinical practice. Considering the reducing waiting times and a most optimizing resource management, which helps to motivate the creation of advanced practice nurse role in our context. Therefore, we consider the importance of set a structured triage system, or also known as Spanish triage system, known for all of the community, healthcare community, as SET. The SET, which in Spanish is the Sistema Estructurado de Triaje, or Sistema Estructurado de Triaje Español. It comes from, or it was created since 2003. The SET was born from two different previous scales, also validated and used internationally to triage the different patients in emergency situation. One of the most known of them, it will be the Canadian Triage and Acuity Scale. And thanks of them, it was allowed to the creation of the SET. The SET, it was accepted as the Spanish triage standard, and it's the most recognized structured triage system used in the Andalusian healthcare context regarding the emergency situation. The SET is a holistic structured nursing triage model applicable to both adults and children, regardless the type of hospital, unit, or care facility in which being used. The SET is a system with excellent reliability and validity rates, computerized and structured in 5 priority levels. The software which coordinate all the mechanism of the set, it's the web iPad, and it's a computer program that helps clinical decision making in triage and allows a greater dedication of the professional to the relationship with the patient by automatically answering most of the questions to set the priority level of the patient. The WebIPad is based on the following criteria. First, we consider need for resuscitation of the patient to set the priority level. Second, the general state, considering vital sign, pain, and emotional state of the patient. Third, risk factors. Fourth, severity scales. And fifth, symptomatic grouping. The classification of patient is structured in 5 differentiated areas or states corresponding to each of the 5 levels of priority in the emergency department. Now we can show an example of the view or screen when we are working with the WebIPad doing the triage of the patient in emergency department. And now we will explain the different level of or priorities and the situation corresponding to each one. First of all, we've got the resuscitation level, which corresponds to a priority 1. And it means that the patient required to be assisted immediately. They got a clinical situation that cannot wait. So for this reason, the assistance for the healthcare professional should be immediate. Secondly, we got the emergency priority. It corresponds to the second level. Some examples should be, for example, critical severe blood loss, or some situation in which the state of awareness of the patient should be inadequate and required an assistant before the first 10 minutes. Following, we found the third level. It's correspond with an urgent situation, but the patient in these cases are conscious, but maybe they've got some breathing difficulties, infection, and the assistant should be before the 60 minutes or 1 hour. The fourth level corresponds to semi-urgent situation. It should be carried out before the 2 hours or 120 minutes. And the non-urgent situation, it's related with most of the administrative aspect, code or situation that it doesn't related with a risk or vital risk with the patient. The assistant can be provided during the period of 240 minutes or 4 hours. Well, in the set, we establish different emergency codes to ensure that that patient which are in the first level of the priority are assessed first, and all the process to give the assistance to them are well coordinated, or as well coordinated as possible. The different codes that we've got are related with most of the most critical clinical situation as acute poisoning, cardiorespiratory arrest, acute myocardial infarction, stroke, severe sepsis, polytrauma, or agitation in patients. Also, the set consider different or specific situation that may vary or requires that the patient are reclassified according or considering this situation of vulnerability. The system of triage that we are using currently, the WebIPad in the version 4, that is the last version, it also consider to assess the pain of the patient which is demanding assistance in the emergency department in a visual analog scale. From 0 to 10, they are asked to provide which level of pain they are suffering in the moment of when the nurse is triaging the patient. Most of the reasons for consultation are classified using the standardized classification of the CIEF to ensure that regardless the unit or the hospital where the patient is being classified, it receives the same reason for consultation and assistance regarding the protocols defined. The set consider also an application to be used by the patient, which allows them to do a self triage in order to make a decision considering their responsible use of the different resources of the available in the emergency, and to promote only the use of the same when it's really needed. As we said before, through the structured self-triage system, which is an application, and a mobile phone application that the patient can be used by themselves, the patient got chance to do a first triage of the clinical situation by themselves, and it promotes a good management of the available resources in the emergency services. It's an example of the different screens that we can see the patient put or provide the different symptoms that they are feeling at the moment or the reason for consultation, and then the application provide them with different information, health education regarding the reason for consultation of the patient. That information and education helps the patient to get a self-management of their health by themselves, and to ensure that the resources are only used for that person who required emergency assistance. Therefore, we could say or conclude that the set contributes definitely to the quality of care in the emergency departments, not only in the healthcare of the Andalusian context, but also in different contexts. That's because it's an integrated element into a continuous quality improvement model with monitoring of triage quality indicators such as arrival triage time, triage duration time, and others, which defines a standard for reason of consultation to the emergency department and allows to evaluate the case mix of the service and to effectively distribute the different resources in a responsible way. So that's the end of the presentation. If you would like to ask any question, I will be glad to address any doubt. Thank you very much.
Thank you very much, Professor Carmen. I enjoyed your presentation. I hope others so. Before I introduce the third speaker, I want to address one question that we received through the chat box. One of our friends asked about the certificate. The certificate will be sent to you via email that you registered yourselves for this webinar. Okay. Thank you again, Professor Carmen, for your great contribution to the webinar. Next, we welcome our third speaker, Professor Abbasi Dolatabadi, focusing on Iranian triage algorithm that we use in our hospitals in Iran. Professor Abbasi, the floor is yours.
Good day to everyone. Dr. Nabi, could you see my slide?
Not yet. Yes, now I can see them.
Thank you. Dr. Márquez, Dr. Rodríguez, thank you again for your presentation. It's very interesting for me. My name is Zahra Abbasi, Associate Professor at the School of Nursing and Midwifery, Tehran University Medical Sciences. First of all, I'd like to congratulate all my colleagues once again on the occasion of International Nurses Day. I'm pleased to explain how emergency department triage is done in Iran. Before I start my presentation, I'd like to explain about the different type of hospitals in Iran. In general, we have two classification hospitals, public hospital and private hospitals. And hospitals provide services in general, specialized, single specialty, super specialty, and hospital specialty referral center. And all of type of hospitals have emergency department, and all of patients are first triaged upon arrival at the hospital. A few years ago, almost 15 to 17 years ago, we have a single triage system in different hospitals, and every hospital uses various systems. And also professionals from diverse fields, including general practitioners, residents from different medical specialties, and nurses were responsible for performing triage. This situation affects challenges in emergency department management, such as increasing mistriage and other problems. After this, Iranian health policymakers decided to select a nurse as the person responsible for performing triage in the emergency department in all of type of hospitals, private or public hospitals. And across the country must be use of this protocol. A nurse who had at least 2 years of experience working in a hospital and at least 6 months of experience working in the emergency department uh, is responsible for performing triage. Uh, all hospitals are required to use the ESI system in normal condition, and start and jump start system must be used in disaster situation. And Emergency Severity Index (ESI) was developed by a group of emergency physicians and nurses in the late of 20th century in United States as a tool to improve patient classification in emergency department. Its primary goal was to create a system that considers both the clinical urgency of patients and the resource required for their treatment. Um, Yes, I made it especially useful in crowded emergency departments. After multiple validation studies, this system was widely adopted in the early 21st centuries across hospitals in the USA and later implemented in many other countries, including Iran. In the ESI, the nurses is specifically responsible for performing the triage. The ESI algorithm provides rapid, reproducible, and clinically relevant classification of patients into 5 groups. From level 1, patient has very severe situation, to level 5. And the latest edition of this triage was published 2 years ago in 2023. ESI triage has 4 important points for decision. And when the nurse wants to triage the patient using this system, they are faced with 4 key decision points and need to answer 4 golden keys. Question is include A. Is the patient unstable and need for immediate life-saving intervention? Point B. Is this a high-risk situation? Point C. How many resources will this patient need? And finally, point D. Do the patient vital signs warrant a reassessment of the acuity level? After answer the question, nurse could decide about the severity situation of patient and decided about this situation. Uh, at the first point, the nurse must be answer a key question, and the level the patient is determined on the answer this question. Is patient need immediate life-saving intervention? Yes or no? If the answer is yes, the patient must be put in level 1 and the nurse needs to start life-saving care intervention as soon as possible. And life-saving intervention in the ESI definite according you see here, airway management, electrical therapy, um, critical procedure, hemodynamic support, uh, and administration medication. Airway management or breathing support is very different from associated ventilation to intubation. And electrical therapy may be include use of defibrillation or emergency cardioversion or external pacing. Crucial procedure may include open thoracotomy or pericardiocentesis, and hemodynamic supports may be use of blood administration or control of external hemorrhage, and medication implemented administration may include injection adenosine, atropine, and other critical drug. And there are different situations that fall into this level 1, such as ineffective airway clearance or ineffective respiratory pattern, flaccid infant, hypoglycemia, cardiopulmonary arrest, or other same situations. Nurse must be provide life-saving intervention as soon as possible. Next step, nurse must be answer to other critical question. Is the situation high risk, or is there possibility that patient's condition will worsen? Does the patient have an acute change in mental status, or is the patient in severe pain or respiratory distress or other distress, for example, psychological distress? If answers to this question is yes, we decided put the patients in the level 2 classifications. And this group may be classified to physical or psychological distress. You can see some situations. For example, for physical situations include sexual assault survivor, includes increasing respiratory effort, postpartum hemorrhage, or sign of stroke or sign of ACS, acute coronary syndrome. And maybe patients experience psychological distress, for example, parental loss or suicidal ideation, plan or attempt, or survivor of domestic or sexual violence. In the latest version of ESI triage, special attention has been paid to disorder in a specific organ, for example, in eye and ENT, and attention to disorder in a special group, for example, in elderly people and children. And in this new update of triage system, there is more detail about children's vital signs. For example, hypothermia is now seen as a sign of sepsis in children and means should be placed in level 2 triage. At the point C, nurses should assess the number of resources needed to treat the patient and grade the patient based on the response to the number of resources needed. You can see resources to consider when making decision about patient's level based on the ESI triage. For example, ESI resources include lab tests, different lab tests, electrocardiogram or radiograph imaging, computed tomography or MRI, magnetic resonance imaging, ultrasound or angiography, intravenous fluid, intravenous or intramuscular medication, specialty consultations, simple or complex procedure. For example, laceration repair and urinary catheter is mean of air resources, and take a history or other physical exam is not resources in the new version of ESI. The patient placed at level 3 or 4 based on the number of resources needed. A level 3 patient require more than 2 resources. And the final decision point is point D. The nurse must be assessed against the patients and re-evaluate and reassessment the patients according clinical condition, vital sign, and required resources. And maybe patients put the up level. For example, put the patients level 1 or level 2. Overall, we could say the ESI triage system is useful and efficient method for triage in very crowded emergency department, such as different emergency department hospital of Iran. And this system have positive point and negative point. One of the positive point of this triage is that it provides a clear and accurate framework for nurses to categorize emergency patients. However, this system is very time consuming to review and assess and determine the patient's conditions and level, and in some cases does not have necessary sensitivity to diagnose the patient's conditions, such as ophthalmic disorders. And in the latest version, the ESI, the designer suggested that use alphabetic triage score for ophthalmology disorder for accurate disorders. Thank you for attention and for this time. Dr. Nabi.
Thank you, Professor Abbasi. I enjoyed your presentation. Thank you very much to all our speakers for their great contribution. Now I will continue the session with my own presentation, focusing on comparing of Iranian and Spanish peri-hospital emergency system. I think we have enough discussion on hospital emergency. Let's extend our borders and go to peri-hospital emergency systems. Just give me a second for sharing my slides. Okay. Do you have my slides, Professor?
No, please try again.
I think it's sharing. So what about now?
No, please open again your slide.
Now I am sharing my slides. Just let me know if you can see them. Professor Márquez, if you can see also, just let me know.
Yes, I can see.
Okay, thank you. So, I introduced myself previously. So this is Nabi Foodani, PhD candidate at Tehran University of Medical Sciences, and I am gladful to have a presentation in front of you and under supervision of these great professors. I'm going to present a comparison between two different models of per-hospital emergency system, the one used in Iran and the one used in Spain. We will also explore two main global models that have influenced emergency service around the world, the Anglo-American and the Franco-German system, as you can see in the first page. These two domain models both aim to save lives, but they differ in philosophy, structure, and practice. Let's begin by defining what is a pre-hospital emergency system. These are medical service provided to the patient before they reach to the hospital. This includes ambulance care, first aid at the scene of an accident, and medical decision made in the field. There are two main models most countries follow. First, the Anglo-American models, and the second, the Franco-German. Both of these models aim to save lives, but they are different in their structures, strategies, and level of physicians' involvement. The Anglo-American system is based on practices from the United Kingdom and United States of America. These models reflect their political, legal, and economic traditions which promote individuals' rights, common law, and democratic governance. This system is also widely used in countries such as Canada, Australia, and India, those countries that have a good relationship with US and UK. In this model, the emphasis is on quick transportation of the patient to the hospital where treatment is provided by hospital-based doctors. So their motto is to scope and run. About economic and global influence of the Anglo-American system. Economically, this system promotes free markets capitalism with minimal government involvement. So these are private companies that play a major role, and especially in the healthcare sectors. So we can guess that these are not free systems, and the patients have to pay for that. Private companies play a major role, especially in the healthcare sectors. The system focuses on maximizing efficiency and profit. So one of the most goals in this system is the profit for the private sectors, often putting shareholders' interest first. Over time, the Anglo-American models has influenced many countries around the world in areas like law, health policy, and emergency care. On the other hand, we have Franco-German system that mostly used in EU, European nation. Now let's look at this system. This system has its root in France and Germany, and after that in whole EU, is used widely across continental of the Europe. This system has it follows a civil law tradition where laws are written in legal codes and must be followed strictly. Unlike the Anglo-American system, the Franco-German model emphasized state control and public service delivery. So the top goal in this system is providing care to the society and to the public, not only profit. The key features by sectors, and we can see here, these are not important, but I want to just mention them for additional knowledge. This model features a strong central government involvement. So the private companies are not engaged. These system work under the supervision of the government. And in the healthcare and emergency service, this model used as a stay and play. So the motto of this system is stay and play. It means the doctors, the physicians, the nurses, the technicians will stay on the field trying to do some advanced procedures in the field and provide care in the field. And one of their motto is we bring the hospital to your home. So this is the one of the other difference between these two systems. And about the economic and global influence of the Franco-German system, this model supports social welfare and not only for profit. These systems are non-profitable and focus on stakeholder-oriented governments. So they pay a lot of attention to workers' rights, to social equity, and to the patient's right, and widely adopted in Europe, Latin America, and part of Asia, like Japan and eastern part of Asia. We have here an overview of each system. The Anglo-American and Franco-German system. The core idea for Anglo-American system is rapid transport to the hospital, so they do not wait. They do not waste time in the field, and they load and go. They put the patients in the ambulance and take it to the hospital as soon as possible. And the Franco-German system core idea is advanced care on the sense. They stay on the sense. They stay on the field and trying to provide care to the patients. About the personal difference between these two systems, we have some information for you in this slide. The responders in the Anglo-American system mostly are paramedics and emergency medical technicians and maybe nurses. They are, in the sense, paramedics and nurses are playing a vital role. But in the Franco-German, we have physicians, nurses, paramedics, and technicians. And the leaders, in the sense, is the physician, not the nurse, not the paramedic. So the physicians will take the leadership role. A scope of practice of each of these two systems are presented in this slide. In the Anglo-American system, on sense treatment, we have the basic to intermediate on-sense treatment. On the other hand, in the Franco-German, we have the advanced one. For the medical authority, in the Anglo-American, the medical authority is removed. The physicians are in the, in the EOC, Emergency Operations Center, and the physicians will remotely make connection with the paramedics on the scenes. But in the Franco-German, we have physicians presented on the side, and on the scenes. Time on sense, Anglo-American system are rapid transporter, so they do not spend a lot of time on the sense, and they just load the patients to the ambulance and go to the hospitals. But Franco-German, they will stay on the sense and focus on stabilization of the patient. About the costs, it's obvious that Anglo-American systems are low-cost systems, and Franco-German are higher because they have to pay a lot of money to their physicians, and they need a lot of more physicians and staffs in their ambulance. And about the structure, EMS as a transporter, they are like only a transporter, but in Franco-German, they are like a mobile intensive care unit. So now let's talk about Iran's pre-hospital emergency system. Iran's system is supervised by the Ministry of Health and Medical Education. The emergency system uses a national voice centralized dispatch, and the emergency number is 115. The main focus is rapid response and stabilizing patients before they arrive at the hospital. So we can conclude from this slide that Iranian systems are different from Anglo-American and Franco-German. It's a mixture of these two systems. Iranian per-hospital emergency system is a mixture of Anglo-American and Franco-German system. It's blending international standards with local needs because there are many shortages in Iranian per-hospital system. So they have to come alongside with these challenges. And these are managed by national and regional health authorities. The main authority is national ones, but the regional health sectors also have some authorities. Each province is managed through medical university in that province of Iran. Official launch of EMS was in 1974 and 1353 in Persian calendar. So it's a very old system in Iran and has a very deep history. The main components of Iranian EMS includes the 115 dispatch center that receive emergency call and deploy ambulance stations. They are urban and rural, fixed and mobile, and EMS personnel in Iranian system are emergency technicians, paramedics, sometimes doctors and nurses. An ambulance fleet is a grounded ambulance like bus, motorcycle, or regular ambulance, and also air ambulance that we use helicopters, and marine ambulance in the southern and northern coastal area of Iran that we have sea. The personnel in Iranian EMS system includes emergency physicians. They are specialized in emergency medicine. They are resident in the dispatch center. Prehospital emergency technicians provide advanced nursing care. Nurses also provide advanced nursing care, and technicians that they are trained in BLS, patient handling, and vehicle operation. Most of the time they are driver. And we have different levels of the personnel in the Iranian emergency system. As you can see, the first responder, most of the time they are technicians. We have the basics, we have the intermediate, and the last one is paramedics that we have in Iranian hospital system. Now, let's look at Spain. Spain has a decentralized healthcare system. This means that each of its 17 autonomous communities is responsible for managing their own emergency service. Most of these regions use the Franco-German model, and this model focuses on having physicians at the sense to provide care before the patient is moved. Spain adopts Franco-German EMS model, as I told you, often referred to stay and play. The personnel in the Spanish emergency system are emergency physicians, nurses, and technicians. Technicians do the vehicle operation. They are, most of the time, they are drivers and help for delivering the patients. Nurses provide advanced nursing care, and the physicians doing providing intensive care to the patients on the sense and in the field. Hospital level care is initiated on site, so they have the physicians on site and started to provide hospital care, reducing the risk of deterioration during the transport. Regional EMS services in Spain are different, and the number also is different. They have in these 17 regional communities. For example, in Madrid, they have SOMA, that's their emergency number is 112. And in the Andalusia region, they have a 061 as the number for the emergency, per-hospital emergency care. About the dispatch, also in Spain, they use 112, as I told you, also 061 for the Andalusia, and call are received at the regional coordination centers. Triage nurses or doctors evaluate the call and dispatch the appropriate resources. Dispatch systems are equipped with GIS and telemedicine support in many regions. They have many types of ambulance. For example, basic life support units, they have only 2 crews, 1 nurses and 1 technicians, and advanced that they have doctors also in the hospital. And like other countries, they have air ambulance, marine EMS, because Spain is like a semi-island, and it's covered by a lot of water around. So, and as I told you, the personnel are physicians, doctors, specialists in urgent care, trauma and resuscitation, emergency nurses that provide advanced nursing care and assist in clinical procedures, and technicians that they are trained in BLS and patient handling and vehicle operation. So this is the end of my presentation. Thank you for your attention. If you have any questions, I am gladly here to answer. And I want to thank you all for your attention. We now have time for question and answer. If you have any question for any of our speakers, please feel free to ask in the chat box. and I will do my best to direct each question to appropriate speaker. Let's begin if you have any question. So before we close, I would like to sincerely thank all of our speakers, Professor Márquez, Professor Carmen, and Professor Abbasi, and of course, everyone in the audience for your participation today. We hope this session has given you valuable insight into global emergency care system. If you have any feedback or would like to connect with us after the session, please do not hesitate to reach out and sending a message via the email or sending feedback on the website. Thank you once again, and I wish you all a pleasant day.